Good evening, everybody.
Good evening.
Yeah, I think it's time we start our AHN Fireside chat. My name is Dr. Egina Francis Makwabe. I'm the nephrologist and consultant physician here in Tanzania. On behalf of AHN, I would like to welcome you all into today's webinar. Today, topic is an approach to acid-base disorder, and this will be covered by Dr. Sishir Gang. Dr. Sishir Gang is a chairman, Department of Nephrology at Muljibhai Patel Urological Hospital, Gujarat, India. He's an ISN fellow, Kansas Institute of Medical Science, Little Rock, Kansas, USA. So, Dr. Shishil also of Pramkashwan Medical College and Sri Krishna Hospital in Karamsad, India. And he was trained for his nephrology at CMC Verol. So today I'll be moderating this fireside chat with Dr. Jonathan Wara. I don't know if he has joined already. Jonathan Wara is a consultant physician in nephrology at Aga Khan Teaching Hospital in Kenya. And also Dr. Ntarindwa Joseph from Rwanda is AHN Chief Medical Chief Medical Director in Kigali, Rwanda. So we are warmly welcome and start your presentation. Karibu and welcome. Dr. Shishir, can you hear me?
Yeah. Can I start now?
Yes, please. Go ahead.
So I'll start sharing my screen. Thank you, Dr. Agina, for the kind words, and Dr. Vincent also for asking me to be part of this meeting. Today, what I propose to do is to take you through a very simple, logical way how to approach an acid disorder. I understand for most of you who are consultants, it may be a review. And for those who are in a training, I hope it stimulates you to look at acid-base disorder in a more logical way. I'll start sharing my screen now. So can you all hear me?
There are some echoes, and I believe all of us should mute our phones. All of us should mute the phones.
Okay, shall I start?
Yes.
Yeah.
Yes, please.
So the task given me was to talk about approach to an acid-base disorder. There are several approaches to analyzing an acid-base disorder. And what I will propose is a very logical, simple step-by-step method, which can be done at the bedside and which you can master very easily. So when you encounter any of the cases of acid-base disorder, you will never find anything very difficult to look at it and will always reach to a logical conclusion. So I bring greetings from Muljibhai Patel Urological Hospital. This is the hospital where I work. And we are located in the western part of India, in Gujarat. And as you know, many of the people from Gujarat are in the states or the countries where you all belong to. And I'm sure you know about Gujarat very well. So the first step is whenever you want to do an acid-base evaluation is to obtain an arterial blood gas. Now, arterial blood gas is not mandatory. One can also do a venous blood gas, but especially in patients who are critically ill, it is good to do an arterial blood gas. At the same time of obtaining an arterial blood gas, you must obtain an electrolytes, because without a complete electrolytes, the evaluation of acid-base disorder will be incomplete. In the electrolytes, I mean, you should have a sodium, potassium, chloride, and a mica. All the four electrolytes are very important to be obtained simultaneously with an arterial blood gas or a venous blood gas. Urinary electrolytes can be obtained for complex disorders, but for today's purpose, we will only look at the arterial blood gas and electrolytes, which will help us in evaluating the patients which you normally see. The second step to understand acid-base disorder is to understand what do we understand by pH and what is its relationship with the hydrogen ion concentration. as we all know that pH is actually negative logarithm of the hydrogen ion concentration. Like all other ions, like sodium, potassium, chloride, and bicarb, hydrogen, unfortunately, we look in terms of the pH, but actually it is also one of the ions only. Important to remember is that the hydrogen ion concentration are much, much lower than the concentration of other ions like sodium and potassium. Hydrogen ion concentration usually in nanomoles. So hydrogen ion concentration usually in the blood is about 40 nanomoles, whereas the concentration of sodium is about 140 millimoles. The difference between hydrogen ion concentration and the sodium ion concentration is almost 1 millionth. That is the difference which is there. So these are very, very small numbers. But it is important to know what these numbers really mean. So if you just can remember, pH of 7.4 would mean a hydrogen ion concentration of 40 nanomoles. So this is important to know that 7.4 pH is 40 nanomoles. As the pH goes down, the hydrogen ion concentration goes up. And as the pH goes up, the hydrogen ion concentration goes down. For simplicity to remember is that as we have a change of 0.3 from pH of 7.4 to 7.1, the change in the hydrogen ion concentration will be from 40 to 80. So roughly it will become double. On the other side, if the pH increases from 7.4 to 7.7, there is a change of 0.3, the hydrogen ion concentration will become half. That's from 40 nanomoles, it will become 20 nanomoles. So this, if you remember roughly, it will give a good guide, and when you look at the pH, you will know what is the hydrogen ion concentration. There are other formulas also, which I put it over here, and also in the handout which I have provided, which you can look at it for knowing it correctly what the hydrogen ion concentration is. So simply put it, 7.4 pH is 40 nanomoles of hydrogen ion concentration, and 7.1 is about 80, and 7.7 is about 20. It's half of that. Once you have known what the hydrogen ion concentration is, we must always check whether the electrolytes that we have obtained on the electrolyte panel and the ABG that we have obtained are all matching correctly or not. Sometimes the ABG and the electrolytes don't match. So how do you know these two things are matching or not? One simple formula is that bicarbonate on the electrolyte should be about 2 milliequivalent higher than the bicarbonate on the ABG, or more or less they are near to each other. Then that will mean that both ABG and the bicarbonate electrolyte panel are matching together. Another way to know is that if you look at the hydrogen ion concentration, the hydrogen ion concentration, the pH, depends upon the PCO2 and the bicarbonate. So this is a very simple formula on the Henderson's equation. The 24 into CO2 divided by the bicarbonate gives you the hydrogen ion concentration. So one could actually calculate the hydrogen ion concentration of pH if you have PCO2 available and the bicarbonate. The way I remember this is that the lungs are above the kidneys, so you have 24 into PCO2 divided by the bicarb. For example, normal PCO2 is about 40 and normal bicarb is about 24. So 24 into 40 divided by 24 would mean 40. And so at pH of 7.4, the hydrogen ion concentration is about 40 nanomoles. It's very simple to remember that you can even find out the hydrogen ion concentration using the available PCO2 and the bicarbonate. The next step is to look at whether patient has got acidemia or alkalemia. The word acidemia means the pH is less than 7.4, whereas alkalemia means the pH is more than 7.4. It is important to know that acidemia means that there is more hydrogen ions and alkalemia is less of hydrogen ions. The word acidosis actually means a process going towards the more acidic side, but it does not mean that pH is less than 7.4. And the word alkalosis means going towards alkalemia, that is towards a higher pH or lower hydrogen ion concentration, but does not really mean that patient has pH more than 7.4. So this is the real semantic difference, but important to understand. The second important thing, once you know that the pH is less than 7.4 and you think about acidemia, one must look at the bicarbonate. If the bicarbonate is low and there is pH is low, then it would generally mean the patient has got metabolic acidosis. And at the same time, if you look at the PCO2, PCO2 should be lower because whenever there is acidemia, the PCO2 should go down. Other way around, if you look at the acidemia is there and the PCO2 is high, that would mean there's got a respiratory acidosis. So like that, first important thing is to obtain a minimum diagnosis. pH low, bicarbonate low, at least patient has got metabolic acidosis. Okay? So that is the first step to know. One thing you have to pick up. pH low, PCO2 high, that means it is respiratory acidosis. So minimum diagnosis you must obtain. So when you look at the ABG and the electrolyte, look at the pH, look at the bicarbonate, and look at the PCO2. Okay, from that we will know very simply whether the patient has got metabolic acidosis or respiratory acidosis. Second important concept in acid-base disorder is to look for compensation. Normally, the body's tendency is to get back to the pH of 7.4. So if you have got a metabolic acidosis, that your bicarbonate is low, the way to get the pH back to normal is to reduce the PCO2. Okay, but whatever compensation the body tries to do, it is not perfect compensation. There is a limit to the compensation, and there are formulas derived at what is the limit of this compensation. Because once you know the compensation, you will know that if a patient is suffering from metabolic acidosis, how good the lung is doing. Is it doing the job is expected to do? That means, is he getting the compensation adequate or not? And there is a handout. Again, I've given all the formulas, but simplicity, I'll just take one example. If you've got a metabolic acidosis, your bicarbonate has gone down. Your PCO2, how do you calculate your PCO2, expected PCO2? Like 1.5 into bicarbonate plus 8 plus or minus 2. This is also known as a Winter's equation, and that will give you the expected PCO2. The first step is that if you've got a metabolic acidosis, you have to calculate what would be the PCO2. And once you know the PCO2, you will know whether compensation is adequate or not. If the compensation is adequate, it would mean the patient has got simple metabolic acidosis. If it is not adequate, then there might be some other disorder also along with it present. Okay, so like that, every time you do it, you must know the compensation. Little bit different for the respiratory thing, because in respiratory thing, when the lungs are at a problem, the kidneys have to compensate, and kidneys can't compensate as quickly as the lungs can do, and therefore, in acute respiratory acidosis, the compensation formulas are different from that in the chronic. In chronic, more time is available for the compensation to happen. So supposing the patient has got acute respiratory acidosis, there will be increase in the bicarb, because if there is increase in the PCO2, the second step for the body to defend is to increase the bicarbonate. To increase the bicarbonate, the kidney has to retain the bicarbonate. And this is the compensation acute, is 1 milliequivalent of bicarbonate will retain for every 10 millimeter rise in the CO2. However, if there is a chronic respiratory acidosis, like a patient of a COPD or chronic obstructive lung disease, the compensation will be much more, because kidney has been seeing this PCO2 for a very long period of time, and the compensation expected is 3.5 milliequivalent of bicarbonate for every 10 millimeter change in the PCO2. So like that, the compensation will depend upon whether the situation is acute or chronic. So once you have known that whether the patient has got a disorder of metabolic acidosis, we must find out the compensation. How will the lung respond to it? Okay, so this is about the compensation. We'll look again at this thing concept when we look some of the problems that we do. The third step is that whenever there is to determine the anion gap. The anion gap basically is a gap. It's not actually a gap, because normally the positive ions in the plasma and the negative ions are equal. But we don't measure all the positive and all the negative ions. And therefore, this is sort of a gap, which is actually a calculated gap, which is created because we don't measure all the positive and all the negatives. So you get a gap which is known as sodium minus bicarb plus chloride. So normal anion gap is about 12. Okay, different laboratories might have some variation, but normal anion is about 12. Whenever the anion gap is elevated, there has to be acidosis. There has to be metabolic acidosis whenever the anion gap is elevated. Sometimes even at a pH of 7.4, especially in some of the university problems, they put it, does the patient has got acidosis or not, and the anion gap is increased. If the anion gap is increased, patient has to have acidosis. Okay, so this is the third step to determine whether the patient's anion gap is normal or increased. And then later on, we'll see whether there are normal anion gap metabolic acidosis or a high anion gap metabolic acidosis. The third step that we need to do is to determine whether the patient has got an anion gap. Whenever there is an anion gap, supposing the anion gap is the patient's anion gap is say 20, that means a normal anion gap is 12. So there is an increase in the 8 of the anion gap. Now, normally what happens in metabolic acidosis is that the rate of increase in the anion gap, that much the bicarbonate will come down. Okay, so what we know as a delta bicarbonate or delta anion gap is a calculated anion gap minus the normal anion gap. So supposing the patient has got an anion gap calculated is 20 and normal anion by the laboratory is 12, then the delta anion gap would be about 8. So this is known as a delta anion gap. Why it is important to know the delta anion gap, we'll see in the second step. So the second step is that you want to know what bicarbonate did the patient start with. Supposing, I'll just give you an example. The patient has got vomiting. Patient is vomiting, the bicarbonate levels will go up because you're putting out acid. So your bicarbonate level in the blood will go up. And then the patient becomes hypotensive. And then his blood flow to the tissues is very, very low. He develops lactic acidosis. So patient has got initially metabolic alkalosis and it then develops lactic acidosis. So when you see the patient, you will not know whether he has got a double disorder, that metabolic alkalosis and acidosis. So to determine mixed disorders, this is a very, very important tool. So you would want to know what was the starting bicarbonate. So the starting bicarbonate is bicarbonate what you find on the electrolytes plus the delta anion gap. So supposing the delta anion gap here we have calculated is 8 in this particular example, and the patient's bicarbonate is 24 when you do the blood test. His starting bicarbonate would be 24 plus 8, that should equal to 32. So this 32 is a high bicarbonate, which indicates that patient would have had metabolic alkalosis before and metabolic acidosis setting. So this is the simple way to know how to determine mixed disorders, that is metabolic acidosis and metabolic alkalosis. So if you remember very simply, the disorders can be mixed sometimes, which you would have read, that it can be metabolic acidosis, metabolic alkalosis, and it can be combined sometimes a triple disorder, that is respiratory acidosis or respiratory alkalosis. Usually you will or never find a situation where there is a respiratory acidosis and a respiratory alkalosis together, because the patient can't breathe both fast and slow at the same time. So only triple disorders are possible with metabolic acidosis alkalosis, either respiratory acidosis or respiratory alkalosis. And we will see some problems how to go about determining this. So let's take up a case so that which will make us more interesting and try to follow the algorithm that I have given you. I also given a handout which you can use to follow the algorithm if you are not followed it up till now, so that we will be able to work through these problems very easily. A 25-year-old woman was brought to the emergency room in an obtunded state. According to her sister, she had been complaining of progressive weakness for 2 months. Examination revealed a generalized reduction of deep tendon reflexes, but no other abnormalities. And the electrolytes obtained in the emergency were a sodium of 135 milliequivalents per liter, a potassium of 1.5 milliequivalents per liter, chloride of 118 milliequivalents per liter, a total CO2, or what we call as a bicarbonate, is 8 milliequivalent per liter. Unmeasured anions, that is anion gap, they already given us the anion gap, is of 10 milliequivalents per liter. On the arterial blood gas, the PCO2 is 40 and the pH is 6.9. Here, they have already calculated for us a pH of 6. As I said, a pH of 7.4 is 100 nanoequivalents or nanomoles per liter. A pH of 7 would be 100 nanomoles, and a pH of 6.9 would be about 125 nanomoles per liter, the hydrogen ion concentration. Here, as you can see here, it is nanoequivalents, whereas most of the electrolytes are milliequivalents. So hydrogen ion concentration is about 1 million times lower than most of the other ions that you see in the body, but it is very, very important. The bicarbonate on the ABG is about 7 milliequivalents, which here is 8 milliequivalents of the electrolytes, which are matching. That means that this report is compatible. And they have given a urine pH is 6.5 and a specific gravity of 1.0. Now let's see how we can calculate. So the first step is to check whether the report that we have obtained is correct or not. So as I said, you can use the Henderson's equation, that is 24 into PaCO2 divided by the bicarb. Here it is 24 into 40 divided by 8, that is 120. And 120, and here what we have given us is about 125. So whatever report we have is a compatible report or a valid report. So there is no ambiguity in the report. Both the ABG as well as the electrolytes are matching very correctly. So we are happy with this step. The second step is to know what is a primary disorder. So here we see the hydrogen ion concentration is high and the bicarbonate is low. Or high hydrogen ion concentration means the pH is low and the bicarbonate is low. As we can see here, the bicarbonate is about 8 milliequivalents and the pH is also low, 6.9. It tells us at least patient definitely has got metabolic acidosis. So the first step in the diagnosis is, what is the primary disorder? Patient has got at least metabolic acidosis, because pH is low, hydrogen ion concentrations are high, and the bicarbonate is low. So at least patient has got metabolic acidosis. So whenever that patient has got metabolic acidosis, you will expect the lungs to blow off the CO2 because CO2 increases the acidity. So if you blow off the CO2, the acidity will come down and the pH will come back and try to bring the pH back towards normal. So what is the expected pCO2? So when your bicarbonate is 8, what do you think should the pCO2 be? Appropriate compensation should be there. So it would mean that 1.5, that is a Winter's equation, 1.5 into bicarbonate plus 8 plus or minus 2. So 1.5 into 8, that is about 12. 12 plus 8 is 20. So you expect the patient's pCO2 should be 20. But if you go back and see the patient's ABG, the pCO2 is 40. So there is some discrepancy. The patients, we were expecting based on the metabolic acidosis, the patient's pCO2 should have been 20. But the patient's pCO2 on the ABG is 40. So there has to be another disorder present. Patient is not breathing as rapidly as the patient is supposed to breathe. So he has got an associated respiratory acidosis also present. So like that, when you look at the compensation, if the compensation is not appropriate, there has to be a respiratory disorder associated. If the compensation is appropriate, no respiratory disorder will be there. So in this case, the pCO2 is 40, which hence the patient has got respiratory acidosis and metabolic acidosis. The patient has got two disorders, metabolic acidosis and respiratory acidosis. Now let's look at the anion gap. As I said, whenever there's a metabolic acidosis, we must look at the anion gap. Anion gap is sodium minus chloride plus bicarbonate. So 135 minus 118 plus 7. So if we do the maths, it will come to around 10. So this is normal anion gap. So usually the anion gap is between 8 to 12. So this patient has got normal anion gap metabolic acidosis with respiratory acidosis. Now we can further go in to find out what are the cause of the normal anion gap metabolic acidosis, whether it has got a GI loss of bicarbonate, diarrhea, or whether it has got a renal loss of bicarbonate, that is a renal tubular acidosis. But for the time being, for today's presentation, we will not go into details of all this, but at least we just try and find out what disorder the patient is having. So patient has got respiratory acidosis and metabolic acidosis. So the question is that patient, how will you manage this patient? So when patient has got respiratory acidosis, and metabolic acidosis, patient's pH is in a very dangerous zone, 6.9. How will you manage this patient? Will you give this patient bicarbonate or will you not give this patient bicarbonate? Important to remember is that when patient has got metabolic acidosis and patient is not breathing rapidly, what kills the patient is potassium and acids kill the patient. So it is very, very important that you need to get the acid back to normal. So in this patient, if you give patients more bicarbonate, what happens? The potassium levels will go down. Already you can see the patient's potassium level is very low, 1.5. If you give bicarbonate to this patient, the potassium levels will go down further and patient will go into respiratory arrest. So there are two options. Either you give patient potassium so that the potassium comes up, or you ventilate the patient. Because if you ventilate the patient, then the patient's CO2, which is actually 40, will come down from 40 to 20, and patient's pH will improve and it will not kill the patient. So whenever such a situation is there, always make sure that you treat the potassium first, and if it is not possible to treat the potassium first, ventilate the patient. Just for the sake of understanding whether ventilating the patient will improve the pH or not, again we can go back to Henderson's equation, which is very simple. 24 into PCO divided by bicarb. Patients, if you increase the PCO2 from to 20, further 20, 20 into 40, it should be here. I'm sorry, it should be. So you bring it down to 20. From 40, you bring it down to 20. Then the hydrogen ion concentration will become 60. That means a pH of 7.2. So just by doing ventilation of the patient, you bring down the pH from 40 to 20. The patient's pH will improve. And once you are in the pH of 7.2, you are in the safe zone. You can supplement the patient with potassium. So the potassium comes up, he starts breathing on his own, and then you can take up the ventilation. If the patient is not in a dangerous situation, you can only give potassium to this patient. It will also do well. Okay. So this is the thing, is that whenever you are faced with disorder, you have to ask the question, what is killing the patient? Potassium and acids kill. So don't give bicarbonate straight away, because it will further reduce the potassium and patient will go into respiratory arrest. So let's move on to the second problem. So the second case is an 18-year-old juvenile diabetic is admitted to the hospital with recent onset of altered mental status. She has had polyuria for several days associated with vomiting and diarrhea. And she complained of thirst and lightheadedness prior to being brought to the emergency clinic. The vitals show that the patient's temperature is 37. The the blood pressure is 120/70 in the recumbent position, and on the sitting position 90/50 in the sitting position, and the skin turgor is poor, and otherwise patient has got unremarkable general examination. So it's a young lady who is juvenile diabetic. She's brought with vomiting and diarrhea and lightheadedness with some degree of hypotension. So when you do the patient's electrolytes, patient's sodium is 134, potassium 4.2, chloride of 88, bicarb of 8, pH of 7.19, PCO2 of 20, the glucose is very high, creatinine is 1.2, and ketones are 4+. So it's typical diabetic which has come with a problem. Let's now try to analyze what are the problems in this patient. So is it a simple anion gap metabolic acidosis, or is it a mixed metabolic acidosis or respiratory acidosis, mixed metabolic and metabolic alkalosis, or is it triple disorder? Okay. So let's see if we can go step by step again and use the same. In the first step, as I said, we must check the validity. Patient's pH is 7.2. 7.2 pH would mean a hydrogen ion concentration of 60 or around 64. We can also calculate the hydrogen ion by using our Henderson's equation, 24 into PaCO2 divided by the bicarbonate. Here's patient's PaCO2 is 20 into 24 divided by 8, which is the patient's bicarbonate, is 60. So yes, whatever you obtained on the electrolytes and whatever you obtained in the ABG, both are matching. Therefore, this report is correct. Again, we go back and ask the question, what is the primary disorder? So you look at the hydrogen ion concentration is high, 64 is high compared to 40, or the pH is low, patient's bicarbonate is low, it is 8. So it tells us the patient at least has got metabolic acidosis. So first thing first, patient has got metabolic acidosis. Second step is to look at the compensation. So again, I'm trying to re-emphasize the same point. Whenever you got metabolic acidosis, patient has got low bicarbonate, patient has got metabolic acidosis, so he has to breathe fast, or she has to breathe fast to blow off the CO2. How much she should breathe? So the expected compensation is 1.5 into bicarbonate plus 8 plus or minus 2. So 1.5 into 8 is about 12 plus 8, 20. So PCO2 of 20, yes, the patient's PCO2 is 20. So patient is breathing appropriately, blowing off the CO2 that is supposed to blow off. So at least patient has got metabolic acidosis and the compensation is adequate. So there is no added component of respiratory acidosis or alkalosis. Now let's calculate the anion gap. So patient's anion gap is sodium minus chloride plus bicarbonate. So 134 minus 88, chloride is 88 plus 8, 88 plus 8 is 96, 134 minus 96 is 38. So this patient has got a high anion gap, which with the patients with having diabetic ketoacidosis would have high anion gap metabolic acidosis. So that is known. Now the question really comes up, is the patient has got only metabolic acidosis, or is there an underlying metabolic alkalosis present or not? So as I talked in the beginning, let's look at the starting bicarbonate. So as we talked in the beginning, the starting bicarbonate is equal to bicarbonate, current bicarbonate, what you obtained on the patient's blood report, and the delta anion gap. Delta anion gap is the calculated anion gap minus the standard anion gap. In this case, the standard, the calculated anion gap is 38. We calculate here the anion gap is 38. And the patient's delta anion gap is 12. So 38 minus 12 plus 8, that will come to 34. So this would be the starting bicarbonate. This patient actually started with the bicarbonate at 34, and then the patient went into acidosis further, and it became 8. From 34 to 8. So that means the patient has metabolic alkalosis plus metabolic acidosis. So high starting bicarbonate indicates the presence of metabolic alkalosis. So if we go back to the story of the patient, they said that she had a lot of vomiting. And whenever you get vomiting, you get metabolic alkalosis. Then possibly she had diarrhea where she would have lost some bicarbonate, and plus she has got diabetic ketoacidosis, and she became acidotic later on. So this is a bit of snooping or to find out whether patient had an earlier metabolic alkalosis to begin with and then superadded metabolic acidosis. So this is a very clear step. The starting bicarbonate is a very simple step to know. Bicarbonate plus the delta anion gap, and that will tell you that the starting bicarbonate was high, and therefore patient also had metabolic alkalosis. Okay, I hope you are able to understand that. If not, we can go back to the handout that I have given and look at it again. But once you practice this, you'll be able to know whether patient has got two disorders, metabolic acidosis and metabolic alkalosis or not. So in this case, patient has got two disorders. Patient has both metabolic acidosis and metabolic alkalosis. So like way you can calculate the disorders. Okay. Now let's move on to the third case. Normally I ask the students to do the cases, but since this is a webinar and we can't really wait, and so I'll look at the third case myself and go take you through the third case. This was one patient which we saw quite some time ago, but it's a very important teaching case. She was a 57-year-old housewife, a known case of type 2 diabetes for 8 years on oral hypoglycemic agent twice a day, and was seen in our urology OPD for left loin pain, and she was diagnosed to have left renal calculus. Her creatinine was 1.4. She underwent an intravenous urogram. Next day morning, she developed loose motions 8 to 10 times with nausea and vomiting. And she got admitted in the hospital at about in the afternoon with increasing breathlessness. So this is a typical case that you normally see. Patients come, they have some underlying renal problem, then they develop some other problem over top of it, and they come very sick to the hospital. So on her general condition was poor. She had tachycardia, acidotic breathing, and appeared dehydrated. On systemic examination, she was drowsy but arousable with no focal neurological deficit. Abdominal examination showed mild distension, but peristalsis were present. Respiratory and cardiac examination were essentially unremarkable. And the lab showed a hemoglobin of 12 grams per deciliter, total WBC count of 29,000. So our total WBC count had gone up, and there were 95% polymorph for nuclear leukocyte sources. The urine showed an acidic pH with a specific gravity of 1025. Glucose 1 present, ketones were absent, leukocyte 10 to 15, and occasional erythrocytes. Let's look at the ABG panel. The ABG showed a pH of 6.8. Again, we can use the formula to know and calculate. This would mean a hydrogen ion concentration of 156. As I said, the pH of 7 is 100, pH of 6.9 is 125, and pH of 6.8 somewhere will come to about 156. Patient's PO2 was okay, 92. Patient's PCO2 was 22.5, bicarbonate of 3.4. Total CO2 was 4.4, and O2 saturation was 88%. There is some movement here, I think, in the thing. The sodium was 135, the potassium was high 7.5, the chloride was 90, the bicarbonate was 3.4, very, very low bicarbonate, extremely low bicarbonate. Creatinine was 3, and the blood glucose was 412. Now, how do you approach this problem? So as I said, first step is to know whether the things are matching or not. So Henderson's equation, 24 into PCO divided by bicarb to know the hydrogen ion concentration. Yes, 24 into 22, that is the patient's PCO2 is 22, and divided by very, very low bicarb of 3.4, which gives you about 155. It matches with the hydrogen ion concentration. So patient's 150 is 150. That means that whatever reports you have obtained, both on the ABG and on the electrolytes are matching. So this report is valid report. Okay. So we cannot doubt the report. So first step again to look at the primary disorder. One primary disorder we must pick up. So patient's pH is low. So hydrogen ion concentration is high. Patient's bicarbonate is low. So patient at least has got metabolic acidosis. Okay. Patient's PCO2 is also low, which favors metabolic acidosis. So let's begin with patient has at least got metabolic acidosis. Look for the compensation. If patient has got metabolic acidosis, you need to blow off the CO2. How much should the patient blow off the CO2? Patient's PCO2 is 1. So Winter's equation tells us 1.5 into bicarbonate plus 8. So 1.5 into 3.4 plus 8, that is about 13. You expect the patient's PCO2 to be 13. Patients to bring the PCO2 to 13 is not very easy. Patients get fatigued. And this patient's PCO2 was 22.5, which was much higher than expected of 30. And therefore, we can say the patient had respiratory acidosis also. Okay. So patient was not breathing as fast as the patient was supposed to breathe. And therefore, there was a component of respiratory acidosis also. So next step, whenever you've got a metabolic acidosis, you need to find out the anion gap. So here sodium is 135, chloride of 90, and bicarb of 3.4. So the anion gap is 41.6. Okay. So this is the large anion gap metabolic acidosis. So now we have to really know whether the patient has got two disorders which you already talked. Patient has got metabolic acidosis, patient has got respiratory acidosis, and patient's anion gap is 41.6. Now the question is, does the patient also have an underlying metabolic alkalosis or not? To determine whether the patient has got underlying metabolic alkalosis or not, we must find out the starting bicarbonate. How would you know the starting bicarbonate? Change in the anion gap is equal to change in the bicarbonate. That is what the principle of the starting bicarbonate is. So delta anion gap is a calculated anion gap. Here we have calculated the anion gap as 41.6, and the laboratory normal is 12. So the delta anion gap is about 29.6. The starting bicarbonate is the present bicarbonate plus the delta anion gap. Starting bicarbonate is 3.4 plus 29.6 is 33. An abnormally high starting bicarbonate is the patient has to have underlying metabolic alkalosis also. If it had been 24, the starting bicarbonate would have been 24, that would have been no underlying metabolic alkalosis. But here we find that delta anion gap plus the present bicarbonate, which is high, tells us that is an underlying metabolic alkalosis also present. And possibly, as I discussed in the previous case, she was vomiting because she had a left flank pain and she was vomiting. So she must have developed metabolic alkalosis. And then she became sick the next day and then dropped her bicarbonate down from 33 to down to 3.4. And she added metabolic acidosis. She was not breathing as good as she was supposed to breathe. And therefore she had a respiratory acidosis also. Okay. So this patient has got triple disorder, metabolic acidosis plus metabolic alkalosis plus respiratory. This is the way you find out the triple disorders. Okay. Now the question is, why did she develop all these things of renal failure? So the reason for getting metabolic acidosis can pre-existing renal disease, volume depletion, contrast, and sepsis. The metabolic acidosis because of renal failure, sepsis, maybe metformin also contributed to the metabolic acidosis. Metabolic alkalosis because of vomiting, and the patient was not breathing as much as you're supposed to breathe, and therefore had a respiratory acidosis. Now this patient would need an urgent dialysis because at a bicarb of 3.4, a pH of 6.8, and here if you go back and see the case, she had a very high potassium was 7.5. Okay, so all this would suggest an urgent dialysis would be necessary. Okay. Before taking for dialysis, if necessary to stabilize the potassium, one could give a calcium gluconate, but otherwise she would be taken for an urgent dialysis. And this patient, we dialyzed her immediately and she recovered very well, gave her antibiotics, corrected her sugars, and she did very well. Okay. So I think I'll just come to an end of this. There are 3 cases which I've just shown you that how you can approach an acid-base disorder without fear. So it's a no fear approach to the acid-base disorder, just a logical step-by-step thing, and you'll always get it right. I've used this for many, many years. A lot of people have done this. There's nothing very novel about it, and they've always got it correct. I'm sure your fear, a lot of the students' fear of acid-base disorders will now no longer be. Thank you very much. And if there are any questions, I'll be happy to answer. I will stop sharing my screen now.
All right, Sishir, that was a very exciting presentation. Thank you for taking time to go through the acid-base disorders. Very interesting. So we are ready for questions. If you have any question, please. Dr. Sishir is waiting. Yes? Hello?
Yeah.
Yeah, anyone?
Sishir, the last case, I just want, can you kindly just repeat that last case a little slow? I couldn't catch the last bit, Sishir. Can you just explain that last case again, please?
Okay, I'll share my screen again. And
yeah, please. Sorry to trouble you.
No problem. So just going back to the last case, I'll just go to the electrolytes and show that she presented with severe acidosis, that is the pH of 6.8. And the bicarbonate was 3.4. And as you know, she had come in the previous day with nausea and vomiting. She had a stone. She had an IBU done. She was on metformin. And then probably she developed some sepsis. So her bicarbonate really dropped to 3.4. Okay. And then when we do the calculations, as I said, the first step is to know, because there is a low bicarbonate and a low pH, so she has metabolic acidosis. So that you agree? So she has got metabolic acidosis. The second part is to look at the compensation, because if you got metabolic acidosis, you need to breathe very rapidly. So according to the calculation, she should have had a PCO2 of 13, but her PCO2 was 22. So obviously she was not breathing as rapidly as you're supposed to do. And therefore she has got respiratory acidosis.
Yes.
Now the third step is to determine what type of metabolic acidosis does she have. Is it a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis? In this situation, if you take sodium minus chloride and bicarbonate, 135 minus 90 and this, so she had a high anion gap metabolic acidosis, which is expected in a patient who is hypotensive and has got metformin on it and has got sepsis and renal failure. So she would have a lactic acidosis and some component of drug induced also. Now here the question is that whether she started with a metabolic alkalosis to begin with and then she got a superadded acidosis. So what we call as a double disorder. Now, how do you know? Now, this is where many times the students find it difficult to understand. So normally what happens is that whatever be the increase in the anion gap, normal anion gap is say 12. So whatever be the increase in the anion gap, say from 41 minus 12, so roughly if you come, it should be around 30. Let's take a round figure of 30. So if the patient's anion gap is 30, then how did she get an anion gap of 30? Because her bicarbonate has to begin with a much higher bicarbonate. So what would be the starting bicarbonate? So patient's current bicarbonate is 3.4 plus this delta Ag would be your starting bicarbonate. So she began with 33. Now normally patients would have had 24. When she had good health, it was 24. And then she started vomiting, so it came to 33. After 33 bicarb, she developed sepsis and hypotension and everything, and the bicarbonate dropped. So this is the way to know whether there is an underlying abnormal metabolic alkalosis, and top of it, patient has got respiratory metabolic acidosis. So this starting bicarbonate, so normally the starting bicarbonate is 24. Supposing in this case, if this delta anion gap had been say around 20, then 3.4 plus 20 would be 24. That would tell us that the patient was okay, and she just started having straight away metabolic acidosis. Okay? So this is a clue to know that patient has got two disorders. I'll just stop.
Thank you, sir.
It's a bit, but if you just go through to the handout and work up every case like that, then probably you will always get it right. I know it's a bit too much in a half an hour of hour's time, but this requires a pen and paper to do it so that you get it right. So normally the students, I ask them to do that.
Sure. Thank you. That's very interesting.
And
would you allow me to ask Amar a question?
Yes, please. Professor Gamal.
Yes, please. Thank you very much, Amar, for your very excellent and very comprehensive presentation. I believe it's requires the basic analytic processes to solve these problems. I'm going to ask you two questions. What is the rate of correction you suggest?
So
the rate of correction
of metabolic acidosis?
Yes.
The bicarbonate correction. So usually you have to really see whether the patient, when you're going to give bicarbonate to the patient, patient's potassium should be okay. As we discussed in the first case, so there should be no threat of potassium. And about, you don't really correct them back to the normal. So about 50% of correction the first 8 hours or so would be okay. So you really get your pH from 6.9 or 7 to around 7.2. So if you just come to pH of 7.2, you're out of a danger zone. So you don't really need to pump in a complete bicarbonate to get them completely back to normal. Okay. So the compensation that you need, you can actually look at, and I didn't really take on to the metabolic acidosis treatment because Dr. Lloyd told me there is another seminar on complete approach to metabolic acidosis where they will probably guide you properly as to the compensations and the corrections. But usually we correct about 50% in the first 8 hours. So and bring the pH to about 7.2.
Yeah. My second question is putting you in a challenge.
Okay.
If you don't have a blood gas analyzer and you can have only the electrolytes, can you solve the acid-base abnormalities with only electrolytes? And my question would go, if you can manage with the sodium and chloride alone?
Then you have to really, if you do not have the pH, because you need to have the pH to know the discernibles. Without pH, then you have to make your guesses in the sense that if you calculate an anion gap, if the anion gap is high, then probably patient has got acidosis. Then you just look at the bicarbonate and then see the bicarbonate. If the bicarbonate is low and the patient is breathing rapidly, then probably patient has got metabolic acidosis. So like that, you can do that, but you have to at least know the pH or a PCO2. If you do not know the PCO2, then you can't really calculate the pH. And in most of the cases, on the clinical basis, in the past, we were doing that. Say patient has got a juvenile diabetic, comes to you with acidosis, breathing very rapidly, bicarbonate is low, and possibly you can tell that the patient has got this. But I would say, unless it becomes very tough then. People try to look at the chloride also. So if the chloride is high and the
Yes.
bicarbonate is low, then there are clues to it to tell you that possibly this patient has got non-anion gap metabolic acidosis. So there are ways to it, but you cannot always get it completely right. So if the chloride, if there's no anion gap and the bicarbonate is low, then patient has got non-anion gap metabolic acidosis. If the patient's chloride, there's high anion gap, then there is a high anion gap.
Actually, I'm asking this question because we can frequently encounter such problems in many low socioeconomic areas where you don't have facilities, and you can have simply the sodium, potassium, and the chloride, and you need to assess the patient clinically. If he has cuspal respiration, he can then have acidosis. You can manage from the urine pH by litmus paper. You can have general ideas when you have very weak facilities. And from the sodium and chloride, as you mentioned, we can see if we have a big gap or not. If the gap between the sodium and the chloride, if the chloride, for example, is not around 100, it's very low, 80, or if it is high, this can give you a very important clue to how to manage the patient without facilities.
True. One could do that. In the past, we were doing the same because when we used to get diabetic ketoacidosis and we didn't have all the good facilities, you would look at the respiration, look at because you couldn't even get a bicarbonate at times very correct, and then start them first, hydrate the patients very well, correct the hydration part, and then still if the patient's breathing not so well, then give bicarbonate and put them on an insulin dextrose drip. So these things we were doing in the past.
Yeah.
Of course, as things become much more advanced.
My other comment about a patient who is diabetic, which is the best treatment to avoid lactic acidosis? It is known that metformin can induce acidosis, but and if you are not on insulin therapy, sure. There is a consideration that the SGLT2 inhibitors can reduce the lactate production, and they reduce the cellular acidity. What's your comment about this?
The SGLT2 can actually precipitate sometimes a diabetic ketoacidosis in a type 2 patient also. So there are, it is not a very benign drug that way. So SGLT2 inhibitors, you have to be aware that even in type 2, they can precipitate diabetic ketoacidosis. So in a patient of type 2 diabetes, if they come very sick because of sepsis or anything, or a sick day, rules are that SGLT2 inhibitors should be stopped because they can precipitate that. And there is a complex mechanism because it interferes with the glycogen, and then you get that diabetic ketoacidosis. So SGLT2 is not really safe in sick patients. But you asked a question about lactic acidosis.
Yeah, it can correct lactic acidosis, but as you mentioned, it can induce ketoacidosis.
True, yes. But lactic acidosis, unlike metformin, which can cause lactic acidosis, especially in patients who are in renal failure. Otherwise, up to a GFR of about 30 or 45, there is no real risk of acidosis with metformin. So metformin can be safely continued up to the GFR of 30, that is a creatinine about 2.53. After that, you may want to take it off.
All right, thank you. Amar Swal has requested, you wanted to talk something. Amar, Dr. Amar?
Yeah, hi, Dr. Makwabe. We should probably allow more questions before, it was more of a closing remark rather than a question.
All right. Okay, any other question, please? Dr. Sishir, what's the role of lactate? Because sometimes when you order, you have a patient in ICU, and then you only get lactic acidosis levels, and you don't have bicarbonate. So how can it help in determining acid-base disorder? Can it be of any help anyway?
Lactate, it is, if you can get a lactate and if it fits into it, it would probably be lactic acidosis. But the degree of acidosis is much easier to know if you have the electrolytes and the EBG. people can use lactate as a guide that patient is possibly having lactic acidosis, but the degree of acidosis can be best determined by EBG. So it's a good way to know if patient has got lactic acid by doing the lactate, but that just adds to the cause for it, but rather does not really help in the management.
So it won't really tell you if there is
Yeah,
a mixed
so generally,
acid disorder.
It is quite obvious in an ICU setting where there is hypoperfusion, the patient's lactate will be high. Unless you are looking at some very rare disorders of intestinal microbiota which is growing lactate. Most of the times I don't ask for a lactate, we just do it with the EBG. But it sometimes comes as a package with the EBG in the machine that tells you about the lactate, and it can guide you that yes, patient has got possibly high lactate, which is contributing to the metabolic acidosis.
All right. Can we get some more questions or comments?
Sure, I just wanted to elaborate on metformin and lactic acidosis in clinical practice.
Yes.
And what is your
We
view on that?
generally see metformin is a very cheap drug and is a very effective drug, and especially in patients who are overweight, and it's a very, very effective drug. So we don't stop metformin till the GFR is about 30 ml. Okay. So because unless and if they come in sick, we stop it at that point. But otherwise, we continue that up to 30 ml of GFR. And in our country, the cost is really low, and we feel that it's #1 drug. And every type 2 diabetic should get it unless the GFR is less than 30 ml. And it's a very, very good and a good drug to be on board. That's what I think. Alternative thoughts, I would like to listen to other people.
Thank you.
Thank you. And a comment? I've seen Dr. Rashid. Yes, go ahead. Yes, please, go ahead if you have any question.
Yeah, I would have a comment when you finish for the Afran, when you finish.
All right, thank you. Okay. Yeah, so we are still waiting for the questions and comments from the audience. If no comments or questions, then I will allow Dr. Amar to comment, and then lastly, your Professor Gamal later on.
Thank you very much, Dr. Makwabe. And I just want to say that I am very blessed to have been working under and learning from Dr. Sishir Gang as my host mentor over the last year that I've been in Gujarat. And as you all saw today, he's a very charismatic teacher, and he's someone you would literally learn something new from, even if you were to spend a few moments every time you were around him. And he's a highly decorated and respected gentleman who is also a strong leader with a great personality, and yet he's a very humble person. I hope to keep learning from and following the example that he has set for the rest of my career, and he is someone that I can only dream of emulating someday. And thank you very much, Gang sir, and also thank you for taking time out and agreeing to speak with us tonight. And I'm thrilled that we had a chance to introduce you to my side of the world. So thank you very much.
Thanks, Amar.
Thank you very much, Sishir.
Thanks, Amar. There is one comment that's a compliment. That the presentation was brief, to the point, and very good talk. Thanks. That is from Ben Lomatoya. Okay, so Professor Gamal?
Yeah, I would like to thank Sishir again for his very elegant presentation, which was very comprehensive and up to the point and very demonstrating. Actually, I would like to inform you that the transplantation chapter of the Afran will be joining the annual meeting of the African Society of Organ Transplantation, which will be held in Cairo in the coming January, 22 of January. And any of you who is interested to join, either by having an abstract or having a talk, he can contact me to put him on the schedule for that meeting. And you will be allowed also to share the meeting by a webinar site, which will be announced on the Afran site as well. Thank you very much for all of you.
And Dr. Kumar, Shishir is
Yes.
one of the lead transplanters in India too. So you have him on board now. So I think you can book him right away. He's one of the
Okay.
lead people. Yes.
You can contact me, Sishir, if you would like to contribute to
a
that
lot of,
event.
living donor transplant is what we've been doing for last 40 years.
Sure,
And
sure.
we do 125 to 130 transplants a year.
If you have my email, you can send me your suggestions how to contribute, and it will be great. I will be very happy to join you to the program. Thank you.
We have also a very active ABO incompatible transplant program. So
ABO incompatible.
Yes.
So you can prepare your data about ABO incompatible and your protocol, and I might give you some slot to present your data.
Sure.
Okay. Okay, that's great.
All right, Sishir, that was very exciting.
Not hearing, Regina.
I
Don't
think we
hear you.
lost the link.
Yeah. Now, that was a very exciting talk, Shishir, and then a step-by-step analysis of the whole situation. And then, especially that last bit was very good. Regina is back. So the last bit, especially the last, was very, very interesting, and how you could actually detect three abnormalities in the patient, and then handle that patient accordingly. And that was a lot of learning. Thank you very, very much, Sishir, and it's really nice to be connected again. And thank you for your time. I know you're a very, very busy consultant and one of the lead nephrologists in India. And thank you very much.
Presentation short and clear with formulas. So if you follow the formulas, then you won't miss. And can it...
Yeah.
Thanks, Dr. Vincent. Thanks, everybody. And it was a pleasure interacting with all of you. And I'm sure I look forward to much more interactions with you in the future.
Thank you so much, Sishir. Thank you. Thank you.
Thank you. Thank you. Thank you. I would like to thank everybody who participated in this presentation. Sishir, welcome you again. Next time, once we need you, you are welcome. And also, I should thank AHN, Lloyd, Nick, and Frida, and everybody who participated in this presentation. Professor Gamal, thank you. So we'll see you next week for the, as usual, AHN presentations. Thank you.